So dear, okay, so shall I start?
Wait a moment, Dr. Maria.
Okay.
Assalamu alaikum, everyone. Today we have our speaker, Dr. Maria Shaukat. She's currently working in Abu Dhabi as a hospital pharmacy with 16-year association as a hospital pharmacist. In Pakistan, she has worked in different hospitals like Aga Khan University Hospital, Ziauddin University Hospital, Hamdard University Hospital, Patel Hospital. In UAE, she has worked in Tawam Hospital, Nova Vita Specialized Pediatric Hospital, Nation Hospital. Now she's currently working in MMC Royal Women Hospital. Her expertise are TPN and IV preparation, and she's also managing the quality projects in the pharmacy. So today we are very lucky to have Dr. Maria Shaukat with us. So Dr. Maria, the floor is for you. So you may start. Thank you very much.
Thank you so much, Rana. And thank you this platform to giving me this chance to present here. So I'm trying my best that मैं कुछ अपनी knowledge आपसे share कर सकूं. ठीक है. तो as Dr. Rana already give my introduction, so I think better I will start now. Okay, so next slide. Okay, so I don't have any financial or commercial interest in this and no relationship to disclosed. Then first of all, the presentation which I'm going to share it with you today is related to geriatrics. Actually, geriatrics is actually the branch of medicines which deals with the problems of the old age pupils, their medical care and treatment actually, and there all the specific problems related to the aging. Actually in geriatrics यानी जो वो लोग जो 60 above हो जाते हैं वो geriatrics की branch में आ जाते हैं और उनका जो geriatrics में सबसे important जो problem होता है वो है aging का. Aging actually एक normal process है जब human body decline करती है after peak growth and development. And this is a normal process for all the human beings plus plants, animals, यानी वो तमाम मखलूक जो अल्लाह ताला ने बनाई हैं तो उन सब में ये एजिंग का प्रोसेस होता है. तो जीरियाट्रिक्स की जो ब्रांच है उनमें सबसे ज़्यादा जो स्पेसिफिक प्रॉब्लम आता है वो एजिंग का है और एजिंग की वजह से ही डिफरेंट देन प्रॉब्लम्स अकर होते हैं. अब एजिंग जो है it's results as a body response to environmental stressors according to the person's health, lifestyle factor together with the genetic makeup. So यानी एजिंग जो है वो आपके environmental stress, persons की अपनी जो एक health है या lifestyle factor है उसके साथ साथ जो genetics है उन सब से मिलकर समझे आती है. लाइक ऐसे कहा जाता है कि आपके पेरेंट्स में ये डिसऑर्डर था तो डेफिनेट यानी मे बी उसकी वजह से आपके अंदर भी आए वो बाद में आपके लाइफ के अंदर या समटाइम्स आपके पेरेंट्स कुछ लोगों में होता है कि फादर मदर को डायबिटीज है, हाइपरटेंसिव हैं तो डेफिनेट ये एक आपका जेनेटिक एंसेस्टर्स की तरफ से चला आ रहा होता है जो कि आपके पास यानी आपकी लाइफ में आगे हो सकता है आपको. ठीक है. Then this is, I told you that geriatrics are those people who are old age above 65 mostly. And again, you know, because of this old age group, they usually have more prone for disability, impaired cognition, increased destructibility towards their disease, and then ultimately then disease and death. Then in journal, sorry, is there any?
Yeah, doctor, you can start. No problem.
Okay, start. Okay. So, so there is actually, if we can see, because of the geriatrics, usually in general, old age people mostly constitute for increased cost on medicine, increased hospital stays, increased medication related hospitalization and medication. यानी if आप geriatrics की branch में देखें तो mostly कॉस्ट ऑफ मेडिकेशन बढ़ चुकी होती है, हॉस्पिटल स्टे इंक्रीज हो चुके होते हैं, उनके मेडिकेशन रिलेटेड हॉस्पिटलाइजेशन या एडवर्स इफेक्ट्स ज़्यादा होते हैं. नाउ व्हाई ऑल दीज हैपन? because of the decline, because of the aging. Okay, so now moving towards the functional changes which is associated with the aging. Quality of life and physical function becomes more important than the duration of life. Means if you have a long duration of life but the quality is not good, you are not enjoying your life, then you will not enjoy anything. So the main functional changes which is related to the aging is geriatric syndromes, which we can say like falls and delirium, which includes actually falls and delirium. And what is the possible etiologies for these falls and deliriums is some psychoactive medications, maybe polypharmacy, maybe hypoglycemia, maybe hyponatremia, UTIs, myocardial infection, yani all those etiologies can cause these two. There are certain risk factors as well which can contribute these, like dementia, stroke, vitamin B deficiency, poor hearing, lack of sleep. These all things then, contribute to these two geriatric syndromes, which is very common in all the old age pupils. Here, one thing which I need to discuss, that in this actually, delirium actually is the abrupt changes of the brain that cause mental confusion. And then definitely because of this, emotional disruption also occurs. Why? If you see some psychoactive medications, then maybe sometimes it causes, the person's mind, yani they will sleep more, and like dementia. The next slide, maybe I will then describe more related to this delirium. And because of this, actually, the instrumental activities of daily life, like shopping, cooking, household work, managing medication, all will be affected. And then activities of daily life, like feeding, dressing, bathing, all these things depend upon these geriatric syndromes. There is certain scale of this, which is called geriatric depression scale, which is from 1 to 15. And depending upon this scale, then we can check the depression scale. So the falls and delirium is the main geriatric syndromes, okay? And all these are the etiologies and the risk factors which can cause these two, along with the aging. Okay, then what is the journal physiological changes in elderly patients actually? Yani when there is normal, this is the normal process na, ke decline aa raha hai. So because of these decline in elderly patient, what are the different changes occur on different systems of the body? Because decline is overall, like it will, the decline is come in the liver function as well, renal function as well, GI function as well. Overall, declines come. So because of this declines, what are the physiological changes occur? I will just quickly share it with you. Like in GI system, there is decreased GI blood flow. There is maybe increase or there is no changes in the pH. There is slow gastric emptying time. And because of this, what will happen? Maybe there is decrease in absorption of some certain drugs and nutrients which require the acidic pH. Maybe the absorption may be rate prolonged because the drug is more retained in the GI system. Then related to skin, there is thinning in the dermis, loss of cutaneous fats. So because of this, the absorption of the transdermal formulations will decrease sometimes. Then body composition also affect too much in elderly people, like decrease body water, increase in the body fat. There are sometimes decrease or unchanged serum albumin. So those medications, like which is protein bound, yani it will then you will find the more protein bound free fractions of the highly protein bound drugs found in the body. Then because of increased body fat, there is decreased volume of distribution of water soluble drugs. Maybe there is increased volume of distribution and accumulation of the lipid soluble drugs. Okay, Then in metabolism, liver, most of the drugs are metabolized through liver. So there is decrease in liver mass, decreased blood flow to the liver. There is changes in this, cytochrome enzymes. So because of this, the first pass extraction and metabolism will be decreased, maybe increase half-life of the drug. So more drug is retained in the body. So then more prone for the adverse effects. There is decreased clearance of drug maybe. And maybe there is, because of the, this enzyme changes, there will be changes in the metabolism phases. Okay. Then renal, and this actually also depend upon the, this person's age, sex, and genetics as well. So after that, there is renal function. So there is decrease, glomerular filtration rate, decrease renal blood flow. So because of all these, there is decrease in the renal elimination of the medicines and maybe increase half-life. So more drug, as I told you, yani metabolites and eliminated drugs more retain in the body. So these are those physiological changes which are very common in the elderly patients or people, you can say, those patients actually. Then this is same as it is the previous slide, but I'm just showing little bit examples of the drug, that when there is decrease in the absorption of the medicines because of the slow gastric emptying time, decrease in subcutaneous fats, and decrease in this, acid secretion. So what are those examples? Some, like there is decreased absorption of transdermal formulations because of the decrease in subcutaneous fat. Then when there is slow gastric emptying time, so more drugs are retained in the this stomach, and they will increase the ulceration, like some drugs, aspirin, NSAID, bisphosphonate, etc. And then certain drugs, iron, vitamin B12, antifungal, calcium, which also affected by this decrease of the acidic medium. Then definite, because of distribution, because there is a like increase half-life because of the lipid soluble medication, because there is decrease in the body fat, increase in the body fat, so they will more retain there. Then there is large fraction of free or active drug in the body because of this highly albumin bound drugs like phenytoin. Then there is decrease, it will also affect the metabolism. So changes in the metabolism because of those cytochrome P450 enzymes. So there is reduction in the first pass metabolism. Then all these, as I told you before, that also, depend upon the age, sex, and whatever the drugs are taking, and genetics, because these elderly patients are usually on the polypharmacy. They are taking so many drugs. So the more they are more prone for drug interactions as well. Then moving forward towards the elimination. So elimination, as I told you, renal function also declines. So mostly maybe mostly people are working in the hospital setting. So they all know that we need to calculate the dose of the drug as per the renal function. So there is a formula I show you here. This is the most common formula which is using in the hospitals for calculating the renal, depending upon the creatinine clearance, and this is called Croft-Gault equation actually. Okay, then there are certain pharmacodynamic changes as well. After this physiological changes, there is certain increase in the sensitivity, like benzodiazepine opioids, they increase sensitivity towards the CNS. So, and like antipsychotic, those patients who are taking antipsychotics, metoclopramide, they are more prone for this extrapyramidal effects and the tardive dyskinesia. Tricyclic antidepressant, beta blockers, antihypertensive, the patient will more prone for orthostatic hypotension. Yani the sensitivity level or the hemostatus will become changed. So we need to take care, yani the prescriber need to take care, and the pharmacist also need to take care while giving or dispensing the medications to the this age group of the patients. Okay, now there is decreased sensitivity of beta blocker agonists and beta blockers. Why? Because beta blockers tends to develop the tolerance because of decreased sensitivity, so they are poorly tolerated, and mostly these are not the first line therapy in the geriatric patients because of this tolerance actually. Okay, then impaired hemostasis like diuretics, angiotensin, AC inhibitors, sodium and electrolytes, and hydration status become change because of impaired hemostasis. Then optimal pharmacotherapy, because most of the drugs having any, especially those medicines which having the smaller therapeutic, window. So there should be adjustment of those medications to reduce the risk level, and age-related whatever drug changes in happening in the pharmacokinetics or dynamics actually. Okay, those adjustment must be done because as I told you, the kinetics dynamics all change because of the aging. So these patients are more prone for accumulation of the drug, and then when the drug is accumulated, they are more prone for producing the adverse effects like benzodiazepines. I told you they have increased sensitivity, so maybe there will be longer sedation period. They will occurs in these age group people. Then drug-related risk assessment. In this, I just took few points like in these age group, sometimes they are overusing the medication. Sometimes some of the patients are underusing of the medications. There is non-adherence of the medication. They are more prone for withdrawal syndromes actually. Overuse of medication, I can say like they are going to several prescribers sometimes, and the another prescriber don't know that what they are using because might be they forget to inform the doctor. So there will be unnecessary drug usage occur. Usually it's occur like GI agents and vitamins because these are the more common medicines which usually prescribers are given for the old age patient to take it. Then underuse of medication, like maybe sometimes they are using inadequate dosing, or sometimes they are omitting the drugs, not taking the drugs because of the adverse effects. So this will be the underuse of the medication. Then sometimes non-adherence, like some patients have dementia, cognitive disorders, some functional disorders, and sometimes cost of the medication also a issue that our elderly patients will reluctant to take the medication because of the cost, and sometimes because of these disorders they forget to take the medication. So there will be non-adherence. So then withdrawal syndromes, like sometimes certain drugs they will do the abrupt discontinuation, like antidepressant, opioids, and hypertensive drugs, and there will be then withdrawal symptoms occurs. So as a pharmacist, we need to do especially the drug-related risk assessment with this type of age group, so not to have these side effects. Then moving forward, this is the journal Physiology Pharmacodynamics, which is related to the geriatrics, as I told you. Now moving forward towards the disorders which are common and in our BCPS course actually. So I will share you those now. What are those which is most common in the this elderly or geriatrics age group? So the first one is dementia. Dementia is actually the decline in the complex attention or executive function, learning, memory, and this motor or social cognition, which interferes with the work or the social function of the person. Dementia is usually about 30 to 50% of the people are 85 years or above, and about 6% are above 65 years who are suffering with dementia. Basically, in dementia, there is you can say that person is mostly there is a cognitive impairment, and they are not mingled with their social or motor functions. So it will cause interference in their social life actually, basically, or you can say the routine life. There are certain levels of this, which I will share it you in the next slides. So points which we need to consider for the dementia is delirium. As I told you previously that I will discuss you in the later slide. Actually, for, for the diagnosis of dementia, first we need to rule out the delirium. What is delirium? As I told you that there is abrupt changes in the brain that causes mental confusion and emotional disruption. Why it happens? Because sometimes the patient is in an ICU, okay, and they are on so many sedatives and hypnotic drugs. So what will happen after when they came out from this sedative and hypnotic drugs? Their mental level is not because they already abruptly changes occurs in their brain. So when they come out from this phase, their mental level is still under confusion. So sometimes they are forgetting the things, they forget that what's going on with them actually, and this there is misconfusion between them that either it's actually the dementia or either delirium actually. And this delirium, the risk factors are medications, chronic illness, sometimes because of infections also it causes mental confusions, metabolic imbalances like low sodium also causing mental confusion. So because of this mental confusion, sometimes it's concept that it's a dementia. So whenever such type of patient, especially those are having these type of drugs, or they have certain chronic illness, or either suffers with some infections, they must be ruled out first that either it's delirium or either this cognition problem. Okay, then mild cognitive impairment, which is MCI, which is actually deficit in coordination and does not meet the criteria for dementia. Dementia is the Alzheimer is the most common type of the dementia actually. So dementia is actually cognitive decline where they are unable to learn, unable to memorize the things, and there is interference actually, which I will tell you in next slide. Okay, that comparison I will show you that how it's happening actually. So the comparison between this you can say dementia with Alzheimer actually. So there are different types actually, we can say, in which we need to diagnose that either this dementia is because of what, how it's happening. So there is MCI, which is mild cognition. In this actually there is no interference with the work or social functions actually. Yani we can eliminate or control those risk factors which is causing this dementia. In this phase, we can use the cholinesterase inhibitors, which can reduce the progression actually, because dementia, we cannot say that dementia will go off after taking the treatment actually. It can just reduce the risk factor or progression only. Okay, so another is vascular dementia. Vascular dementia occurs because of the stroke actually, and usually the onset occurs within 3 to 6 months of the stroke. It's not like that patient have a stroke and they have this type of symptoms. So sometimes because of the stroke, some focal neurological symptoms occurs, and maybe abrupt deterioration will go on step, yani the progression is stepwise actually. In this type of dementia actually, we need to control the cardiac and vascular risk factor, and yani there the cholinesterase inhibitor and other glutaminergic therapies are not effective actually, because this is not the actual dementia. This is because of the neurological problem which occurs due to the stroke actually. So we need to control those risk factors actually here. Then Lewy body syndrome, which is actually you can say it's a motor function of Parkinson's disease actually. And in this type of dementia, actually it's associated with the abnormal deposits in the brain, and it will affect the brain then, and which can leads to the problem in thinking, movements or behavior actually. So this is actually the deposition and nothing. This any protein depositions you can say abnormal. So it can create symptoms which is similar to dementia. And especially in this type of dementia, we need to avoid atypical antipsychotics because this can worsen these motor symptoms. But we can use here the cholinesterase inhibitors. Usually in this type of dementia, Lewy body, motor features of Parkinson's disease is actually more commonly you can see this type of dementia. Then another is dementia of advanced Parkinson's, PD, which is Parkinson's disease. In this, actually, there will be a problem in cognitive functions, and it usually arises in the later stages of the Parkinson's disease. Okay, initially, usually physical symptoms are usually related to the movement. Actually, in this one, so in this type of dementia, we should have to avoid the typical apsychotics as especially which may worsen this motor symptoms of this Parkinson's. And we can use also here is in this stage of dementia the cholinesterase inhibitor. Then there is one type which is called frontotemporal dementia. Okay, this is not common actually, usually not commonly occurs in the old age people. And this is actually, in this type, actually, usually the brain lobes are shrink. And then it can then affect the brain, and this will affect ultimately the behavior, language, and personality problems. So cholinesterase inhibitor may worsen the behavior and cause agitation. So here actually usually SSRIs or trazodone may be beneficial to give actually. Then there are certain reversible causes, means because of some disorders, sometimes dementia can occur. As I told you, like the delirium, where we are just need to diagnose first before the dementia diagnosis of the dementia. So same like that, because of some of the problems, dementia occurs, but this can be reversible if we will do the standard protocols, replacement protocols with them, like vitamin B12 deficiency. It's also progresses sometimes memory loss because of anemia and folic acid decrease. So for this type, if we diagnose this one, and this is how we can check this one with the vitamin B12 serum concentration. So after, because once diagnosed, then we will replace the vitamin B12 according to that standard protocol, so it can reverse the memory loss. Then hypothyroidism. Okay, actually it's a study actually experimental studies actually that subclinical hypothyroidism also associated with cognitive impairment actually. So which will induce this our amyloid precursors in the brain, which is a major component in the brain, and it will then cause the cognitive impairments. So we will, the same like vitamin B12, we will just replace the levothyroxine as per the standard protocol, and then it will cover those functions. Then depression. In the depression as well, sometimes the people have this thinking of I don't care response, or they have trouble in the concentration and the memory as well. So this type of behavior as well, we will use the treatment protocols for the depression. Then there is NPH, which is called the normal functional hydrocephalus. Actually, it happened when there is fluid actually build up in the brain actually because of some reasons without increasing any actually pressure. So this type at this time, it will also, causes the cognitive impairment actually. And how we can avoid this or improve the symptoms by doing, this surgical placement of this ventricular shunt to remove this, excess water, and then the symptoms will be, improve the symptoms of this dementia. So these are some, examples actually. Then there are some assessment tools for dementia like MMSE, SLUMS examination, Montreal Cognitive Assessment, mini cog assessment. I will just go through this slide because this slide I just take it from the book. So there are certain assessment tools. These are mostly the self-assessment or questionnaire type exam to check the patient that at which stage they are, and how their mental status actually, so that because of this we can then check that either it's a mild stage, moderate stage, or severe stage. So as you can see down the table, the MMSE square is a 30-point scale. So 20 to 24 is a mild. Then between 10 to 19 is a moderate, and less than this 10 is a severe stage. So there are different functional losses or cognitive impairments, which I will just quickly tell you that what happened in the mild stage. There is short-term memory loss, word finding difficulties, that they cannot find the words to say a full sentence, you can say, or share their problem. Uh, then example of functional loss. Functional loss is like there is loss of instrumental activities, daily activities like laundry, housekeeping, managing medications. Yani they cannot manage these type of things. Then in moderate state, maybe the patient will become disorientated. They are unable to engage themselves in the activities or conversation. Yani they are hesitant or irritated to do that, and they need assistance in activities of daily life, such as like bathing, dressing, toileting. Yani they need someone to take them to the washroom. They cannot do dressing and bathing alone. Okay, then in severe is actually, you can say, they are totally dependent, and they have loss of speech, they have ambulation problem, incontinence of bowel and bladders. Yani they are, you can say, maybe bedridden after all these. And the basic, yani even they cannot do the basic activities of daily life. Yani they are totally dependent on the someone. Yani they need round the clock care at this stage. So you need to at least memorize this scale, because sometimes this scale, they are asking the question in the exam, and they are putting this scale. So depending upon this scale, you can then find that what is the stage and what therapy you can give it to the patient. Then now moving forward towards the pharmacological treatment. This is the chart. There is two types of the drug which we are using in this treatment: cholinesterase inhibitors, which includes donepezil, rivastigmine, and galantamine. These are the doses. You just need to memorize some doses actually, and especially the common side effects, because sometimes in exams they are asking related to the these side effects and the drug therapy related to the stages actually. Okay, so cholinesterase inhibitor, actually these are the drugs which are prevent the breakdown of acetylcholine, and therefore boost the cholinergic transmission actually. So in dementia people, actually there is a decreased level of acetylcholine. That's why these cholinesterase inhibitor then stop that breakdown, and then these are then showing a good effect actually in the dementia syndromes. And now the another is so these are the all drugs. These are the dosing protocols. Okay, and these all three drugs are labeled for mild to moderate, and moderate to severe Alzheimer disease. Rivastigmine is also coming in the transdermal patches. So sometimes there is skin disorders will happen. And this drug rivastigmine is also used in Parkinson's disease as well. Okay. Sorry. The last drug, which is galantamine, this drug is also used for mild to moderate, and this is preferable to administered with the food, and renal dose adjustment is necessary for this drug. Okay. Then we have another class of drug, which is glutaminergic therapy, which is having memantine. This is the dosing, starting dose and maintenance doses. This is actually works with the blocking the N-methyl D-aspartate, which we are abbreviated as NMDA receptor blocker. And it also again blocks the glutamate and neurotransmitters, and then improves the improves the learning and memory symptoms. And actually all these therapies need actually 3 to 6 months to evaluate. And with the tools which I show you, the scales, we will then check the patient after 12 weeks therapy, that either there is any improvement or not. And if there is improvement, even we cannot abruptly discontinue the therapy, and tapering needed for all to discontinue or reduce. Because if we abruptly discontinue, then the withdrawal symptoms, right, rebound agitation can occur in these patients. Then there is combination product. Once sometimes when one therapy is not working, then you will move to another therapy, and when then it will also not work, then there will be a combination therapy we can use, like the cholinesterase inhibitors along with the glutaminergic therapy. So there is a combination product available in the market, donepezil plus memantine. Okay, it's also need the renal dosing, and it's commonly used sometimes in the severe stage. Then there are certain adverse effects, and I give you the suggestion that the common adverse effect should be memorized, because sometimes the question comes related to the side effects. So if you know the side effects of the main pharmacological group, then it's easy for you to answer the question. So what are those? Like, because as I told you, cholinesterase inhibitors, they are actually overall increase in the acetylcholine, so there is then overstimulation of this parasympathetic nervous system, so there is increase in the secretions, diarrhea, bradycardiac problem occurs, like bradycardia, orthostatic hypotension, syncope, in genitourinary, there is incontinence occur. Then long-term adverse effect, there will be anorexia, weight loss, sometimes maybe fall, and because of the fall, there is fractures occurs. Okay, then glutaminergic therapy, usually the common side effects are agitation, urinary incontinence, insomnia, diarrhea, dizziness, confusion, and headaches. Okay, so now there is one clinical case which I just shared with you. There is a 75 years old woman with Alzheimer who lives at home with her husband and has been treated with donepezil, yani cholinesterase inhibitor 10 milligram daily for about 3 years. When she began the therapy, her MMSE score was 21 to 30, which you can say in a mild stage. Her present score is now 17 by 30. Okay, yani there is not that much difference occurs within this 3 years. Now the patient cannot perform most of the instrumental activities of daily life, but can perform mostly activities of daily life with queuing, means with the help of someone. About 2 months ago, her donepezil dose was increased to 23, but she couldn't tolerate, and it was reduced back to 10 milligram. Her husband asked about changing her drug treatment to help maintain her function. So which is the best choice? So here the best choice is actually to initiate the memantine. Why? You will just underline the question to understand first. This is old age people. Her MMS score, she is taking around 3 years this cholinesterase inhibitors, but her score is not improved too much. Okay, then after that they increase the dose, but she cannot tolerate, so it will be returned back. Means cholinesterase, now you cannot give this cholinesterase inhibitor to that patient. So if you can see this one, then this donepezil, because ribostigmine, also the cholinesterase inhibitor. So the choice of D is remove. Now, again, retry of donepezil, we cannot give because already they increase the dose, but she cannot tolerate. Vitamin E doesn't have any role in our this dementia. So the choice only remaining here is memantine, which is glutaminergic therapy, and we will go to another class of the drug. If it's not work, then we will go for combination drug. Okay. So now, sorry. What is this? Okay, now there are certain behavior symptoms which will occur with the dementia actually. So I will just go through. This is the chart that in mild stage, there is memory loss, mood swing, personality changes occurs. This is all at a mild stage. Okay, lack of interest towards the, different things. And then there will be yani the mild executive functions they cannot perform. Then 15 to 10 is the moderate level where they are unable to learn. Maybe starting of aggression and psychosis occurs. Maybe there is confusion, they need assistance in their activities of life. Then in severe there is gait change, means they are unable to work, they are confined to bed, maybe incontinence occur, maybe loss of activities of daily lives. Yani they are confined to bed means yani everything will do by other pupils. They are confined. Then we have another slide which is treatment now. This type of, because these are behavior syndrome actually, so in this type we have certain like I told you, sometimes symptoms occur, behavior symptoms occurs. So these symptoms, like if there is anxiety, then we can go for anti this SSRI, SNRI, antidepressant type of drug. Then apathy means there is lack of interest in the work. So then we can go for this methylphenidate. There is a effect. Short-term study says we can also go for this cholinesterase inhibitors, because they are, this is the earliest symptoms that they are not memorizing the thing, they are not showing the interest because they can't understand actually or confused. Okay, then there will be depression, maybe they are these changes occurs in the behavior actually. So depression patient also, in Alzheimer disorder we can go, because most of the 80% of the patient have depression with Alzheimer disease actually, because they are thinking that they cannot do anything, they are dependent on the others. So here also we can use SSRI or metazapine. This is usually giving the options of the treatment. Then wandering, like walking here and there, and from one place to another and cannot understand the thing. So here we can this type of patients, no drug will stop the patient from wandering actually, so we cannot do anything in wandering. Then there is hallucination and paranoia. This is actually what will happen in this, there is aggressiveness and anxiety level will come out, because and they will think negatively actually. Yani you can say that psychosis and delusion will come. So in this stage or this type of behavior, then antipsychotic drugs is can be tried, like risperidone, olanzapine, quetiapine, aripiprazole in this one. Okay, then aggression and resistance to COVID. This is the most difficult and best response is to treat non-pharmacological. And in this one also because patient is aggressive or agitated, so we can use, these are the investigational drug can be used here, like pyrazosine, quinidine, citalopram, like SSRI here. So these are the behavior symptoms which is related to the dementia with those type of patients. Then we have another disorder which is most common in the geriatrics patients, which is urinary incontinence. What is urinary incontinence is actually unintentional passing of the urine because of the loss of bladder control. it is a very common problem actually, and million of the people are affecting with this age people actually. The psychology, just a little bit physiology, I will share it with you, that when the bladder is filling actually, so beta adrenergic stimulation relaxes the detrusal muscles to increase the capacity to fill actually. Then alpha adrenergic stimulation tighten the internal bladder sphincter to hold actually. Then acetylcholine M3 mediated involuntary bladder contraction occurs when the signals goes that this is the normal emptying time actually. So it will contract. Then normal bladder emptying time occurs after that with the decrease in the urethral resistance and contraction of the bladder muscles. Because of the aging actually, as we discussed in the previous slide, there is decrease in the functions. So also decrease in the bladder elasticity and capacity. There will be more frequent voiding occur actually. As well as postmenopausal women, there is loss of estrogen decline occurs. So that will also affect the elasticity of the muscles and the bladder outlet, and urethral resistance will also decrease. Then in especially in men actually, there will be enlargement of prostate glands, which will also decrease the flow rate of the urine. And there will be a very nice one picture I took it to understand its physiology. You can see first the bladder filling, muscles relaxed, sphincter contact, and then pelvic floor also contract. Then first sensation comes. Second, when the bladder is half full, here yani it's a time when you will have a sensation. Then normal desire to void come, and then at the end maturation process occurs. The detrusal muscles contracting, the pelvic floor relax, and then easily flow of the urines occur. Now there are different types of urinary incontinence actually, and these are actually I will say you like urge and overactive bladder actually. Okay, in urge and overactive bladder is actually sometimes usually because of the infection and because of the involuntary loss of the urine. In this actually loss of a moderate amount of urine with an increased need to void. In this actually detrusal muscles instability can be caused by CNS damage. Sometimes it's a stroke as well. Okay, and there will be some infections as well, which can cause this type of problem. Okay, then in this one, cholinergic drugs can stimulate the bladder like botanicol and cholinesterase inhibitors also using in here. Then there is stress incontinence. What happened in stress continence, that loss of a small amount of urine with increase in abdominal pressure like sneezing, coughing, and usually it occurs in the postmenopausal women, you will see. Okay, and there is a decrease of the estrogen as well, which causing also the resistance. So alpha blockers such as prazosin also decreases the urethral sphincter tone. We can use in this type of case. Then we have overflow. Overflow is occurs usually when there is urethra block, like in BPH. BPH is having in overflow incontinence because prostate is suppressing this urethra, and the bladder cannot be empty completely because of this obstruction actually. Okay, and PVR, yani post-voidal residual, is often high, which is greater than 300 ml, indicating incomplete emptying time. Yani with this one, you can see that more urine is inside the bladder actually. In this type of incontinence, the drug-induced causes, the drugs which can induce this one is anticholinergic drugs as well, calcium channel blocker, opioids also, decreased detrusor muscles contractions. So these, the first column is the description, and the last one, sometimes drug-induced also these type of symptoms actually. Then there is functional incontinence. Functional incontinence is actually because of any disability, which is then not working properly with the bladder, and then person is unable to go for toilet or reach to the toilet. Like if maybe the patient have rheumatoid arthritis, so they have problem joints pains and problem with the joints. So maybe they have mobility problem and they cannot reach on time to the washroom. So this is called functional incontinence. And then the drugs like sedative drugs, mostly elderly patients are taking these drugs and they are get confused. So they will they have you can say more in a sedation phase. So they will confuse and they will mix that either they need to go for voiding or not. Okay, diuretics also increases the voiding actually, as we all know that it will increase the urination. So sometimes at this stage people they have more voiding. Then mixed incontinence. Mixed incontinence is actually the one in which there are two types of incontinence mixed together. So in this type of case, we need to check which is the actual cause and then treat. Like maybe stress and overactive bladder both together, have any patient have problem with these two. So we need to check first that which is the main cause and we need to treat as per the diagnosis. Then this is also one picture of types of incontinence, that is stress incontinence, in which is because of the abdominal pressure. Then there is urge continence, in which due to involuntary, this contraction of the bladder muscles. Okay, and then overflow, which is because of the blockage of urethra. Then neurogenic, which is due to disturb in the nervous function. As I told you, some people have Parkinson's, diabetes, some different problems which is connecting mental impairment. Also, this comes under this functional type actually, the neurogenic incontinence, because there is some functional problem occurs. Because of this, they are unable to void. Now, the drug treatment. There are different type of drug treatments, as you can see in this slide. The urge and overactive bladder, actually antimuscarinic and anticholinergic drug we can use in this. So it can relax the bladder muscles actually. Okay, so in this antimuscarinic drug, oxybutine, tolteridone, solifenacin, and physotaurodine, so many drugs are there. So these are used actually. The clinical efficacy of these drugs are modest actually, and difference in adverse reactions exist. So depending upon the efficacy and these side effects, we can choose the drug for the those patient actually. So longer acting formulas are also available, and they are better tolerated in old age people actually. Then there is beta agonist, which we can use, which is called mirabegron. It's also well tolerated, but has not been compared with the antimuscarinic actually. Most commonly actually antimuscarinic and anticholinergic agents are used in this type of urinary incontinence actually. Then there is ona-botulinum toxin A. This is actually injections which are giving in intradetrusal muscles, detrusal muscles actually. They will prevent the stimulation of the muscles, and pre-procedure antibiotic recommended for this type of injections, and may cause urinary retentions and must be able to perform self at this stage. With this, self-catheterization is important. Then there is stress incontinence. In this, alpha-adrenergic agonists are used, but there is very limited efficacy data. Then topical estrogens are more commonly used in stress-related incontinence. So conjugated estrogen vaginal creams and estradiol vaginal suppositories rings are coming in the market for this. So they will improve the severity of stress in continence actually. Then it's not FDA label, but in stress incontinence, this SNRI reuptake inhibitors like duloxetine is also using, but not FDA, so the use is limited. Then overflow. in overflow, actually, alpha-adrenergic antagonists like alphazosin, tamsuline, sildenafil, doxazosin, terazosin, prazosin are used. Okay, the adverse effects also vary depending upon the selectivity, which medicine we are using. Okay, and alfuzosin, sildenafil, and tamsuline are more specific and usually preferred in old age people. Then 5 alpha reductase inhibitors, which is finasteride and dutasteride. This is actually to slow the progression of this, and they will actually reduce the size of prostate and alter the PSA value, which is prostate specific antigen. I will describe this in later because we have one more topic of BPH, so we will discuss there. Then cholinomimetics, that is betanicol. It's also stimulate the detrusal muscles, but also have systemic cholinomimetic effects actually. That's why a little bit less use. Then phosphodiesterase type 5 inhibitors, which is ditalofil. It's also used for the BPH problems actually. Then in functional, as I told you, there is no drug treatment. We will just check that what is the cause which is causing this incontinence. So we will do the intervention in this and remove the barriers which is causing the obstruction in between this. Then mixed incontinence, in which there are, as I told you, 2 or more than 2 types are involved. So we need to focus on the predominant symptoms and do the treatment for that one, that component actually. Okay, then non-pharmacological interventions, we need to do exercises and weight loss, especially for those patients which have body mass index greater than 25 to 30 kg per meter square. Then there are, for stress-related incontinence, there is very famous pelvic floor exercises, which is also called Kegel exercises. These are the first-line therapy actually for the stress urinary incontinence. Then stress incontinence usually responds to surgical repair as well, that if it does not work, then go for a surgical repair. Another is like urge. In urge actually, we have again pelvic floor exercises in combination with the medication for urge or mixed UI. Then bladder training to increase the time between the voiding in the urge continence. We can do this. Scheduled and timed the voiding. It will help the patient, especially with the dementia patients, that you will schedule every 1 hour or 2 hour, whatever, for them. Then prostatectomy in men's or self-catheterization for severe overflow. This is usually because, as I told you, that in BPH, so BPH, when it's not work, the medication not work, so there is prostatectomy, the removal of the prostate, yani cutting. It's actually called TURP, actually, sectional urethral cutting actually. So, and also sometimes people will go for self-catheterization, yani they will put the urine back. Then there is one clinical case related to this UI. I will share it with you to give you the idea that how the questions are coming in the paper actually. So a 75 years old woman reports urinary urgency, frequency, and loss of urine. When she cannot get to the bathroom in time, she also wear a pad at night that she changes 2 or 3 times because of incontinence. Her medical history is significant for MCI, yani she has cognitive impairment, osteoarthritis, and hypothyroidism, means they have some functional issues as well here. Okay, then physical urine analysis is negative, physical examination is normal, and her PVR is normal, like less than 100. So which therapy would be best to initiate for this patient? Now here actually, this seems like urge incontinence, okay, because she has some functional issues as well. She has involuntary loss actually, okay, and scale, yani she has mild coagulation. So here pelvic floor exercise with drug therapy should be initiated. because this migabatron, as I told you in the previously, that it's not a it's not a best treatment choice because it's a newer drug. Then this darifenacin also should not be used as a initial therapy. And any migabatron is because of a newer drug, less evidences, that's why. And this tolterodine is actually also not preferred because the patient has MCI, so it's not preferred here because maybe it will worsen the cognition problem actually. So the choice here is C, pelvic floor exercise and solifenacin, which is your alpha adrenergic anticholinergic drug. Then it's wind up here with the urinary incontinence. Then we have another topic, which is benign prostatic hypertrophy, BPH. And then it is actually usually occurs, there is enlargement of the prostate. Usually it's developed after age of 40. By age of 60, 50% of all men have this BPH, and by age of 85, mostly 90% men's having this BPH. The pathophysiology and clinical presentation, I will little bit share with you that how it's occur actually. As I told you, there is normally with aging, all the things changes. So there is change in the male sex hormones as well. That comes with aging, and it's a factor actually here in BPH. Type 2 5-alpha reductase actually facilitate conversion of testosterone to dihydrotestosterone, which is resulting in prostate growth. So this is the main pathophysiology. Then there are certain, lower urinary tract symptoms which occur with this. Which is like voiding, obstruction symptoms, decreased pose, decreased hesitancy, there is dribbling of the urine. Then storage, irritative symptoms, like because you have bladder, urine in the bladder, but you have urgency, but you cannot void actually. There is dribbling, nocturia, in the late night during the sleep, you feel that you need to go to the washroom, but you cannot void freely actually. Okay, and dysuria, maybe there is less urine. So for these type of things, there is American Urological Association Symptoms Index, AUASI. This score can help us to determine the severity and appropriate treatment for the BPH. Higher number will indicate there is more severe symptoms actually. Then evaluation criteria of this is medical history. And medical history, we can do digital rectal examination, which then estimate, by this we can estimate the size and shape of the prostate. Then blood, urea, nitrogen, serum creatinine, urine analysis, because all these are changes because of this enlarged prostate. Then there will be prostate specific antigen level, which is very suspicious for the possibility of prostate cancer. Okay, so treat with 5-alpha reductase inhibitors at this stage. So because this can suspect the prostate cancer, how I will say is that there is some point level, value level, like 0 to 2.5 nanogram per ml is the safe. Then if 2.624 is also safe, but depend upon the risk factors, also suspicious. But 4 to 10 is the suspicious, this value is suspicious for the prostate cancer. So the patient will go for further evaluation to check for malignancy. Okay, then if there is significant urinary retention suspected, assess the PVR, as I told you, post-voidal residual volume, which is there. If it is greater than 50, then patient have an elevated risk of infection, because the more urine is in the bladder, retained for longer period of time, it will create more prone for the UTI infections actually. So assess for the medication also, which may exacerbate this BPH symptoms, like alpha adrenergic agonists, this decongestant. They can stimulate smooth muscles contraction in prostate and urethra, and then obstructing urinary flow. anticholinergic drugs, they also yani urinary or GI antispasmodics, antihistamines, TCAs, inhibitors. These also can reduce the ability of the bladder muscles to contract and empty the bladders. Diuretics also increase the urinary frequency and volume, so it will also exacerbate the BPH symptoms. Then testosterone replacement also stimulates the prostate growth. So we need to assess all these medication if patient is taking and having the BPH. So we need to assess, and if we can stop those medication or decrease the dose to not to have these type of symptoms for BPH actually. Okay. Then we have the treatment. Okay, evaluation criteria I already discussed you. This AUASI score actually 0 to 7 is mild, then 8 to 19 is moderate, and candidate is ideal for the treatment. Then 20 and more is the severe, and for this we can go for prostatectomy. Then we have drug treatment. In drug treatment, the first option usually alpha-adrenergic blockers. These are used in moderate to severe scores of the AUASI. Doxazosin and terazosin decreases the BP. So the patient who having this BP problem, hypotensive problem, cardiac problem, it's not first choice there. Then tepsoline, sildenafil, alfuzosin is less associated with hypertension, so we can utilize those with these patients these drugs. Then temsolene is also causing intraoperative floppy iris syndrome. This is actually syndrome where this those patients who have cataract and they will go for a cataract surgery. So these people are more prone to poorly dilate their retina actually. This is called pupil actually, dilate the pupil. So this is called actually floppy iris syndrome. So temsolene is causing this thing. So we need to check before starting this temsolene that patient having this cataract problem or no. Then 5 alpha reductase inhibitors, which is finasteride and dutasteride. There is no superiority over these two agents, but these are only reserved for with the large prostate volume, which is the for more than 40 grams. If the patient having more than 40 grams of the prostate gland, then we will start this medication. Okay, and for this actually also baseline PSA test is recommended because it may lower the PSA and then cause cancer. Okay, then we have phosphodiesterase inhibitor. This is PDIs, which is tadalafil. This is not FDA recommended. In FDA does not recommend actually in combination with alpha blocker. Why? Because it causes hypotension. So all this PDIs will never ever use with all the vasodilators or this type of blockers because it can causes hypotension in the patients. Okay, or either if they are using, then should be 4-hour separation of the doses between this phosphodiesterase inhibitors and the alpha blockers. Then there will be combination therapy with large prostate size and elevated PSA. Then there will be some combination therapies like 5 alpha reductase inhibitors along with the alpha adrenergic blockers we can use. Then in the more severe symptoms, then the last option when there is no medication responded, then the patient will go for surgery, which is called transurethral resection of prostate actually. Then there are certain supplements, which is there are systemic reviews and suggesting their use, but actually like saw palmetto plant extract and beta citirol, they have shown some benefits in the studies actually. And even this saw palmetto plant extract, if this agent is used with 5 alpha reductase inhibitor, they maybe reduce the efficacy of this. So these are just study drugs, investigational herbal drugs actually. Okay. Then there is one clinical scenario related to this topic. An 85 years old man with the LUTS visit the physician who determines his AUASI score 15. His blood pressure is 117/70 mmHg, sitting position. A digital rectal examination confirms the diagnosis of BPS, and the physician schedule a further workup, including a prostate ultrasound, which shows a prostate volume of 31 grams. Which therapy is best at this stage? The answer is C actually. Why? See, this score comes under this moderate. If you see here, it's under moderate. And then this patient having hypotensive at sitting position. Okay. The volume is 31. So 31 means less than 40 grams. So we cannot use 5-alpha reductase inhibitors. So B and C option is class. We can remove now. Then patient has decreased hypotensive. So terazosin is causing hypotension. So this is also then cancel out. So now the best option here is temsolene, which is alpha adrenergic receptor. Okay. The next topic is related to osteoarthritis. Okay. Osteoarthritis is also the most common form of arthritis, which is associated with aging and highly affecting the large varying joints like knee and hip, is most commonly affected in osteoarthritis. And it's very common nowadays in our old age people. The pathophysiology, there are certain risk factors like age, female sex especially, obesity, genetics. Sports activities also can cause this osteoarthritis in old age people. Then occupation, what type of work they are doing. Either they are putting stress over their over these joints. Then maybe sometimes previous injuries also causing. Then acromegaly and other chronic illness also will be a risk factor for the osteoarthritis. Sometimes repeated micro injuries also initiate and accelerate the process of osteoarthritis. And in this osteoarthritis, sometimes loss of cartilages occurs. And this cartilages, occurs in the joints, which is balancing the chondrocyte functions actually. So either formation of chondrocyte, they will shift towards the destruction actually, because chondrocytes are usually responsible or they in the formation of cartilages, and these are actually building blocks you can say, which is involved in the rebuilding of cartilages, chondrotin actually. So this is some studies shows that these this chondrotin is reducing the pain, but in osteoarthritis this is shown actually, but it will take several weeks, 2 months to initiate this one. So cartilages actually basically the cushion in between the two joints, actually bone joints. So if it will deteriorate, then bone will rubs together and then causing the pain and also do the destruction. So goal therapy is what actually to relieve the pain and swelling and maintain and improve the joint function, prevent the loss of function of the joints, and maintain or improve the quality of life. As I told you, in all these old age people, their quality of life is destroyed because of all these, different problems because of aging. So our task is to improve their quality of life by doing some interventions or by giving some, pharmacological or non-pharmacological therapies. So in osteoarthritis, what are the drug treatments actually? The first line is the acetaminophen, which we can use as needed. Maximum 4 gram dose can be taken by usual dose. 4 grams or sometimes 650 milligram Q6 hourly given, but we need to inform the patient or check the patient for hidden acetaminophen and ensure the patient that they are not taking any other medication which is having acetaminophen to decrease the risk for hepatotoxicity and the risk of especially those patients who is having the liver diseases, because it can create hepatotoxicity, as we know, the acetaminophen. Then the other choice is NSAID. If acetaminophen will not respond, then we can use the NSAID, but usually avoid the chronic use, because these are when we are giving NSAIDs, we should need to use along with PPI, especially with the patients who have gastric problems or gastric ulcer. And also, there is a cardiac risk with those, so we have to monitor especially those patients who are hypertensive and those who have having a renal problems. So we need to monitor those patients who have these type of problems, who's taking the um, NSAIDs. Okay. Then naproxen is the safest one with respect to the cardiac risk. Then there are certain topical agents. These are usually for knees or small joints, and this will reduce the adverse effect actually. So preferred in the 75 years and above patient to use. These will give superficial, pain relievers. The most common drugs which are used as a topical agents are diclofenac 1% gel and capsaicin gel. And for capsaicin gel, we need to counsel the patient because it will take time to produce the effect, mostly like around 2 weeks. So they don't need to skip or stop applying this cream. And it's a local irritant type of cream, yani gel. So we need to inform or counsel the patient to wear the glove during the application. Then after this, we have intra-articular injection. These type of injection we will use when the above oral drugs will not work. So methyl prednisolone and triamcinolone are the drugs which we can use and repeated every after 3 months actually. There will be the risk of septic arthritis actually with those. But if it is not work, then hyaluronic intra-articular hyaluronate injections also given. Okay, if it is the glucocorticoids are ineffective. Then glucosamine sulfate, as I told you, this with or without chondroitin can be considered for chronic therapy, but they are not used for the pain reliever. This is just to support the or improve the cartilages rebuilding actually. Then the last option is opioid. This is used for moderate to severe pains of the osteoarthritis, and usually those patients, elder patients, which are not respond to the initial therapies of acetaminophen and NSAID, and they are also not having a cannot use the chronic any use of NSAIDs, yani they are not a there is a no choice for NSAIDs, then we can use the opioids. And tramadol alone or in combination with acetaminophen can be used for yani choice of drug for these type of patients, okay, who will not respond to the above therapies, especially the oral one, the acetaminophen or NSAIDs. Non-pharmacological treatment, you can say we need to educate the patient for lifestyle and expect them to seek the care when needed. We need to inform them to decrease the weight, especially to have the decreased biomechanical loads on these weight-bearing joints, because it will also help to decrease the pain and disabilities. Then exercise is one of the important thing for the osteo, even the rheumatoid arthritis patient, because it will strengthen the muscles, which will then ultimately support the bones actually. Then physical and occupational therapy also one of the thing. And also especially we need to tell them to take more calcium and vitamin D, hot and cold packs, and decrease the stress. At the end there will be the last option is the surgery after all these. If all these not work, then there is joint replacement surgeries, which is now very common, hip replacement and knee replacement. But this is the last option when nothing work and the patient will suffer with more pain or severe stage. Okay. Then there will be a clinical scenario related to this topic, and maybe now we are having a last topic after that to wind up this. Uh, Sorry for this delay, and that's much long, because maybe people were thinking that geriatric is a small topic, but it's not a small one. So anyhow, just be patient for the last topic. So the clinical case, an 85 years old man represent with pain from hip osteoarthritis. He has hypertension, coronary artery disease, BPH, and his for his osteoarthritis, he has been taking acetaminophen 650 milligram 3 times a day. He reports that acetaminophen helps, but the pain persists and limits his ability to walk, which is the best next step for this patient. So actually here we need to add hydrocodone with the acetaminophen. As I told you, in old age patient, it is a best choice actually, or common choice. Why? Now patient has BPH, hypertension, coronary artery syndromes. So this celecoxib or ibuprofen we cannot give here. Okay. Then glucosamine is not a choice for the pain reliever. This is just a supporting drug actually, so we cannot use here for this patient. So the best option for this patient is uh, to add hydrocodone with the acetaminophen. Then the last topic, which is very common in geriatric patient, is rheumatoid arthritis. This is actually systemic disease, which is actually usually affect the small joints of the hand, wrist, and feet, and it's an inflammatory disorder actually, and autoimmune as well. It's usually occurs increasing prevalence up to the age of 40, and it's having a strong genetic predisposition for this rheumatoid arthritis actually. And uh, usually you can say this is same like osteo, but in osteo the large joints are involved, whereas in rheumatoid arthritis small joints with inflammation actually involved in this one. This is an autoimmune disorder actually, what in which actually the body itself mistakenly attack to our own immune system and destroying this, and this will work against to our system, like SLE, arthritis, rheumatoid arthritis, sarcoidosis, myasthenia gravis. All these comes under autoimmune disorders actually. And the pathophysiology and clinical presentation, we can say that the initial inflammatory activation is unknown, but once it's activated, it will produce antibodies against our antibodies and cytokinins against our own immune system, which will accelerate the destruction of the cartridges and the joints actually. And patient with the presence with the joint pain in this, the clinical presentation, patient will come with this, joint pains, morning stiffness, fatigue, other inflammatory symptoms, and which includes like the patient will feel hotness, redness, swelling around the small joints, which is usually symmetrical distribution. And sometimes this rheumatoid arthritis also affect the other organs like pulmonary fibrosis, causing pulmonary fibrosis, vasculitis, dry eyes, which is called Sjogren syndromes. And what are the laboratory tests by which we can check the rheumatoid arthritis is positive RA factor, elevated sedimentation rate, which is we call ESR, C-reactive protein also high. This anticyclic citrullinated peptides, this is the most sensitive test. If it is elevated in the blood, means confirmed rheumatoid arthritis actually. Then there is increase in ANA. It's also show that our immune system will attacking itself towards our body. And usually as well as what else, these antibodies, CBC also, because it's then showing anemia, in these type of patients actually. So these are certain laboratory tests which usually prescriber prescribe to diagnose the rheumatoid arthritis. And anticyclic citrullinated peptide is the more sensitive test actually for them. Then non-pharmacological treatment for this rheumatoid arthritis, rest is the best option. When there is disease exacerbated, the best option you have to do the rest during this period. Occupational and physical therapy also support the mobility and maintain the functions of the joints. As I told you that exercise is the best option also, because it will give you muscles to support the bones, because muscles will strengthen with the exercises, and then ultimate this muscles will support the our bones actually, okay, and joints. Maintenance of normal body weight, because overweight also put the biomechanical stress over our joints, which will also then causes disease exacerbation and pain. Then assistive devices are if needed can be used, like the support bandages, and you can see the I forget the exact name of those. There are certain bandages and this devices coming, the which you can use in case of pain to support the joint. Then the last option also, surgery for the tendons and joints can be done when there is no pain relief or no treatment improves. Then pharmacological treatment, the treatment goal is actually to control the inflammatory process so that disease remission occurs, and the patient will having improved quality of life. Because of this, there will be relief of pain, maintenance of the function, and improved quality of life. This treatment response we can measure by reduction in the number of affected joint, their tenderness, swelling, pain, improvement in pain occurs, then decrease in the morning stiffness. Patient will not feel the morning stiffness in the joint. Reduction in serological markers such as this RF factor, ANA, or this CCA, citrullinated peptides. So these serological markers will decrease, and then ultimate there is improvement in the quality life scale, that patient will can do their work in an improved way. Then there is now pharmacological treatment. We have two classes of drugs, like disease modifying anti-rheumatic drugs, DMARDs. In DMARDs, we have non-biological DMARDs and the biological DMARDs. In non-biological DMARDs are the first line treatment actually, and treatment approach, as I told you, initiate DMARDs within 3 months of diagnosis. Usually methotrexate is preferred drug in the DMARDs. Then we can step down, we can go for step down approach, which is that after starting the DMARD together with steroids and NSAID to control the pain, because NSAID or steroid will decrease the pain and the inflammation, controlling the inflammation so that the damage will reduce towards the joint, and then ultimately reduce the DMARD slowly. Do not discontinue, never ever DMARDs, even if the patient is in remission phase. Otherwise it will increase the inflammation, and then exacerbation will occur. This is the last topic actually, so I'm just winding up because it's too late now. So pharmacological treatment, then methotrexate is the most commonly used drug because it's have long-term data as well and better outcomes. Hydroxychloroquine, sulfasalazine is slow onset drug, but these two drugs can be a choice in pregnancy. Leflunomide is substitute, but with efficacy comparable with methotrexate, it's okay. Then combination of DMARDs can be used for the patient with poor prognostic indicators. You can use the combination of the DMARDs in those which having a poor prognosis. Okay, then moving forward to next slide. Now, biological DMARDs. After non-biological, there is biological DMARDs, which is used in combination with methotrexate for severe disease. Actually, we can use this, or if non-biological DMARDs are ineffective or contraindicated to those patients actually. Okay, TNF inhibitors, which is called tissue necrosis factors. It includes this infliximab, Intaracept, adalimumab, rituximab. Then we have non-TNF biologicals. Then it is abatacept, anakinra, rituximab, too much difficult, medicines to pronounce. Then biological kinase inhibitor, which is tofacitinib. Okay, these are all biological DMARDs actually. These drug is actually also help to stop the inflammation, because these are actually suppressing the immune system by blocking this protein which is called TNF, and because this factor is actually causes inflammation if it is overactive in the body. So these are TNF inhibitors, so these will suppress this one, so it will decrease any inflammation and reduce the damage to the bone and cartridges actually. But this biological DMARDs we are using at the end when the previous medicines, the non-biological DMARDs not work. Okay, because there are certain side effects as well with those drugs. Then NSAID glucocorticoids, both can be used for immediate pain and inflammation relief. Then NSAID do not affect disease progression in this one. It's only actually used for analgesic effect, but it will cause weeks and sometimes several hours of administration to produce the analgesic effect, but anti-inflammatory effect will take 1 to 2 weeks of daily dosing actually with these type of patients. Then glucocorticoids, it's usually not recommended for long-term basis because of the adverse effect and complications, but it's used as a bridging therapy to provide an anti-inflammatory effect while we are using until the DMARDs will, take the effect actually. Because as I told you, it will take at least around weeks for DMARDs to produce the effect. Now, in pharmacological treatment, I will not go through too much in depth for this slide. This is, I took it from the book, this BCPS book. So these are the drug therapies which can be used, non-biological and biological DMARDs and their dosing protocols. So you will just go through this one from the book. Because I already discussed that these drugs, we will use it. So what are the dosing and what are, how the effects will occur, what are the side effects and all these, this is all in this slide, okay? So you need to just go through by yourself, okay? So these are all those drugs. Then a comorbid condition, like sometimes patient have some different disorders as well with the rheumatoid arthritis. So we have to take care, like in cardiovascular disease, avoid TNF factors in patients with congestive heart failure. Low dose aspirin, omega fatty acids, statins, or combination therapies should be considered to reduce these CVS risk factors. Then infections are elevated with the especially pulmonary infection and sepsis with this type of drug. So tuberculosis screening is required for those patients if we will go for biological DMARD therapy, especially. Immunization are best given before initiating DMARDs or biological therapies. At least 2 weeks waiting time is recommended, especially for live vaccines, okay? Avoid zoster or other live vaccines I told you previously, while the patient is taking DMARDs and biologics, should be waiting time in between them and should be avoided. Actually, live vaccine should be avoided in with this biologicals. Okay, then patient with hepatitis C and B, if treated with effective antivirals, are treated with the same as patient without hepatitis. However, with untreated disease, DMARDs are preferred to TNF inhibitors, okay, for these hepatitis patients. Then malignancy is also is more common, particularly GI cancers and lymphoproliferative proliferative disorders. Osteoporosis also common in RA patients. Calcium and vitamin D is recommended, as I told you previously, to take. Bisphosphonate also should be considered for the prevention if prednisolone 5 milligram or more is daily prescribed. Yani, we all know that steroids will go for osteoporosis if we will take more. So these type of patient we can prescribe bisphosphonate. Okay, so that's it to the geriatrics. And then there is a clinical case related to this. Last 65 years old woman received a diagnosis of RA 1 year ago. At that time, her RF titer was 1:64. She presented with joint inflammation in both hands and about 45 minutes of morning stiffness. She begins a therapy with oral methotrexate and currently receive methotrexate 15 milligram weekly, folic acid 2 milligram weekly, ibuprofen 800 3 times, omeprazole 20 milligram. At today's clinic visit, the patient reports the recurrence of her symptoms. Radiographic evaluation of her hand joints reveals progression of joint space narrowing and bone erosion. What is the next step? So here it's answer actually A. Why? Because the patient already have a stiffness. She already tried this methotrexate, yani non-biological DMARDs, and she doesn't have improvement in the her symptoms, you can say. Okay, as I told you that leflunomide and hydroxychloroquine having slow onset of action, and it also comes under DMARDs. So we cannot use this one. Then prednisolone is using for the bridging therapy to improve or the inflammatory process of rheumatoid arthritis. So it cannot be used. So the best choice is A, which is biological DMARDs. So that's all for this. Now these are some sample questions which I am sharing with you. So you can go through this because these type of questions comes in my paper. So I am sharing to you to have an idea related to the geriatrics. Like what is the difference between delirium and dementia? I already discussed with you this one. A lady in middle age has suffering with the spell of urine. This is actually not the exact one, but I'm just sharing you to have an idea because there is a long cases actually. So you can go through this. So you will have idea. So that's all for this geriatric. I hope you understand, and from my side, wishing you good luck for your exam. So Rana, Kamran.
Ji, Assalamu alaikum, Dr. Maria. How are you? It's really well explained. No doubt. It's a bit long, but it's well explained. तो मेरा ख्याल है कि अगर वक्त थोड़ा सा ज्यादा भी लगता है तो doesn't matter, लेकिन समझ में पूरा आना चाहिए.
Yeah, बस I hope कि समझ आ गया हो.
No doubt, we have very good comments about your lecture. तो मेरा ख्याल है कि if there is any question, we will just collect the question and we'll get back to you.
Exactly, no issues.
We cannot, yeah, we cannot take it more long this lecture anymore.
Yeah.
And I can understand. I can understand you're already tired and it's very long. I really, it's hats off to you. Your efforts, you really did a great job.
Thank you so much. Thank you so much. No issues. Thank you for you guys to give me this chance. So whatever questions actually you want to